Welcome to this webinar with Ramón Gómez Meda. We have a great topic today, from analog to digital dentistry, from state of the art to the matrix. Before I pass the word to Ramón, my name is Holger Kast. I am the head of training education at TRI. I'm going to lead you through this webinar, and there's certain rules for the webinar. During the presentations, you have the possibility to put your questions in the question mark field on the right side, in the toolbar on the right side. Just write down your questions. I try to pass all the questions at the end of Ramon's presentation to Ramón. If we can't answer all the questions, we can do a follow-up via email to answer all your questions. But before I pass the words to Ramón, I would like to take the chance and quickly introduce you a little bit to our TRI philosophy, or our TRI implant system. First of all, we have we are Swiss. We are a Swiss, 100% Swiss-made implant system. I'm just sitting right now in front of the lake of Zurich in our empty office in this moment to do this webinar. We work after a performance, which means we have created an implant system the last 10 years. Which works with the highest gold standards of the industry. Simplicity is one of our important parts in this system. So we try to keep everything very simple. We have a very lean product portfolio for the existing implant system. We have a very lean surgical kit for all our implant lines, a bone level and a tissue level narrow implant. We have one surgical kit, one drilling protocol, which keeps implant placements very simple. The Think Digital is today a very big topic, and I think in total the most important part, the Think Digital means we creating already the last 10 years great products in the digital prosthetic workflows, and with the matrix implant, which we're going to introduce you today. We have also the world's first digital implant created. More of this with Ramón in a few minutes. And all of this we offer for a fair price. Happy birthday, TRI. We have the 10 years anniversary this last week, actually. We have on our website, you can see a lot of great things from the last 10 years, and just pass by our website, TRI website, and maybe you can even leave a video hello from your side to us for the happy birthday, for the birthday of the TRI system. In the last 10 years, we created innovative products from implants. Started by implants with a bone level implant, with a narrow implant at 2011. From the beginning on, that was a hexagon connection, compatible to the most common hexagon connections in the world. That means we have an open interface. The TRI Plus is our digital world, and with this open interface, we were from the beginning on of TRI, you were able to do prosthetic-wise digital workflows. In 2014, we added a tissue level implant, which is already a very unique tissue level implant, because I think it's an aesthetic tissue level implant. We have a lot of customers who use the tissue level implant in aesthetic zones, because we have a pink colored neck, and this has a very big aesthetically advantages. And so this implant, the tissue level and the bone level, is same surgical kit. So also there is the simplicity given. We created the first touchless carrier of the implant. Our packaging, the 3-pot in 2016, is, I think, a very unique and great packaging of the system. And let's go into the digital developings a little bit more. In 2017, we created our very unique tie base. We call it the TRI base. And I know that Ramón is using this TRI base in the analog ways or digital analog ways. already in his daily business with us. And the TRI base is unique because it's individualizable. You can cut it in height and angulation, which is we have a patent on it, and which is quite unique technique and a great tie base for octagon connections and hexagon connections in the industry. And so then we have in 2018 we created, and this comes a little bit to the topic of today, analog to digital. We created the so-called 3D touch impression post, which is an impression post and is also a scan body. So it's a hybrid product actually. So you can take open tray impressions without a screwdriver. All of you who take open tray impressions know that the screwdriver can be a problem in narrow spaces. And we have in the same product, it's a scan body. So you can do intraoral scans with it, or also extraoral scans with it. So it's a two-in-one product, which shows again the simplicity. But then in 2020 we were able to get the CE marking for the world first digital implant, the so-called matrix implant, or the matrix technology. I would like to get a little bit the details or the background of the matrix connection. In the past, the digital industry like CAD/CAM technologies came into the implantology, and so CAD/CAM technologies and also materials like zirconia or PMMA, milled materials came into the industry. And so we have this mismatch between these new technologies like CAD/CAM and also zirconia and the existing, but you can see here on the right side, existing connections. All these connections, tapered connection, hexagon connections, external, internal, octagon connections, and so on. These are all, let's say, old-fashioned connections. They are made 20 years ago, 30 years ago, even 15 years ago. And in this time, the milling technologies like CAD/CAM technology just entered the market in prosthetic way. And so there is still a kind of a mismatch between these connections, which are not made with the knowledge of zircon or these CAD/CAM technologies. And therefore, we always need to use an abutment in between, a tie base in between, to create prosthetic on top of implants, and with a tie base we need cement and so on to cementate the zirconia materials on top of these tie bases. And that's why there is this mismatch, and that was the reason why we as TRI created this digital implant, the world first digital implant, the matrix. And this is a little bit, you can see here the design of the matrix. I don't want to explain too much about it because I know Ramón is going to show a little bit more the details of this matrix connection. At least I would like to tell you that in this moment with the matrix, we go into another chapter of implantology. We eliminate the abutments. We don't need cement anymore, and we have no limits because it's all digital design. So from the implant height or bone level height or tissue level height, you can create in any limits. You have possibilities, angulated place implants, and anyways, you can put a prosthetic on top of it without the need of an abutment. The last year, in the last quarter of year, we have get the CE marking approved, the CE marking for Europe, and the FDA is following. We created 6 world first features. I think Ramón is going to explain a few of these features for sure in his presentations. We have 8 unique patents for the next 20 years on this digital implant connection, the matrix, and we already won the Red Dot Award in 2020 for the matrix technology. The last quarter of 2020 we used with in Europe, especially, that has a little bit to do with the COVID situation. So we have in Europe already more than 25 KOLs which have their first experience. One of these is Ramón Gómez Meda, and we created all around Europe already, or we replaced a lot of matrix implants so far. From single crowns up to, as you can see here, full arches without an abutment, up to 90 degrees of angulated placed implants. You are still able to screw retain them in one piece. And I think this is the time when I pass the words to Ramón. Hello, Ramón. I would like to please introduce yourself. We can switch the presentation mode to you. And remember, the questions you have to Ramon's presentation, please write them in the question field in the toolbar on the right side as questions. Please write them during Ramon's presentation in this block. Okay, Ramón, I change you to the presenter.
Good morning. Hello from here from Spain to everybody all around the world. Thank you for being there. And as Holger just said, first of all, I want to thank three guys, three company for the kind invitation once again. Holger, can I ask you, are you watching my slide? Yeah.
Yes, everything works perfectly, Ramón.
Perfect, and the sound is perfect as well. Okay.
Perfect.
Thank you so much once again for the invitation. Thank you for the effort, Holger and Valentina and Sandro, everyone. Okay. And we are going to speak a little bit, as Sandro said, as Holger said, sorry, about the transition from analog to digital. I have many slides and not much time, but I will try my best. And as you know, every time we speak about the digital, so sorry, the digital world, we are used to see these images, intraoral scanners, CAD/CAM design, but we don't usually speak about the implant connection. And in this lecture, I want to speak a little bit about the implant. This is a kind of a new design orientated to the digital world. First of all, we will speak a little bit about the advantages of immediate implants, because this is a lecture which topic is immediate implants. And why immediate implants? Because in the 21st century, for me, immediate implants is the way to go in most of the occasion, most of the clinical cases, because we reduce the morbidity for the patient. The cost is lower, and of course the treatment time as well. So we face many different clinical situations. Sometimes the cortical plate is pristine. Sometimes we don't have much bone on the back side of the socket, maybe because of a fracture or an endodontic problem, whatever. Or sometimes even I have a gingival recession. So every single case, as you know, is quite different. Some cases are more demanding than others. And if we study the literature, we pay attention. Many authors say that when the bone is pristine, when the cortical bone is present, there is no problem. We go for an immediate implant, but many papers say that if the cortical bone is not preserved, maybe the more predictable way to place the implant is in a delayed way, to wait after the extraction, maybe for 6-8 weeks and before waiting for the soft tissues to heal before placing the implants. But we all know that it's been widely published that after taking a tooth, the bone collapsed, the socket, the cortical bone collapses, and we can preserve some of that bone, but we cannot preserve 100% of the bone. of the socket. It's impossible. This is well published. And the reason is that the facial cortical bone is very thin. In 60% of the cases, its thickness is around 0.5 millimeters. And in most of the cases, 90% of the cases, is less than 1 millimeter. So that's one of the reasons why the cortical plate is more resolved in the anterior area than in the posterior area, where the cortical bone plate is thicker. But of course, the other reason is because this cortical bone plate is vascularized from the periodontal ligament in part, and when we take out the tooth, the periodontal ligament dies, and afterwards the bone gets remodeled. So then that's the reason for 2 decades I've been grafting connective tissue grafts, not always when the cortical plate is thick or when the phenotype is thick. I don't need a connective tissue graft, but in many cases with thin biotype, we graft a connective tissue graft on the back side of the implant between the cortical plate and the gingiva in order to compensate that bone collapse we were talking about. In 2017, Levine published this paper, and this is more or less the protocol I've been following for these 2 decades. In order to avoid these aesthetic complications, the gingival recession on the back side of the implants, the bone collapse, the gray color of the abutment, or even the gray color from the neck of the implant. These aesthetic complications in young patients are quite relevant. Maybe mainly if the patient has a high smile. And you can find almost, sorry, you can find this kind of, I cannot see. If you can see my lecture if I reduce the window of the software. How is it running?
We can see it right now perfectly.
Okay, perfect. Thank you.
Yeah,
thank you.
So it's perfect.
So how many times do we face gingival recessions, aesthetic implant complications? In this paper published in 2009, the authors say that in 30% of the cases, we can have this kind of aesthetic complications because of the facial bone, the thin facial bone, the thin biotype or phenotype, call it as you want, or the facial implant malposition, mainly if the implant is positioned too buccally, the bone is gonna be more remodeled. So before placing an implant immediately, mainly in the anterior area, we should study the aesthetic risk assessment published in 2009 by Chen and collaborators, okay? Because this is a highly risky area. These are the situations we try to avoid in our patients, and you know very well that we are seeing more and more patients with these problems. So first of all, we should analyze 3 main points before placing an implant immediately. The condition of the hard and soft tissues, which is the condition of the bone, what kind of biotype is present into the mouth of the patient, thick or thinner, where is located the margin of the gingiva, how much bone do I have, and the shape of the bone. Do I have enough bone to stabilize my implant immediately or not? And I shouldn't take only a CBCT. I should analyze with a dental probe, a periodontal probe, where the cortical bone is present, because sometimes the cortical bone is very thin and we don't see that bone in the CBCT images, but the bone is present, is still present. Then we should know very well the characteristic of our implant, which what is the design of the implant, the macro and micro design of the implant. And finally, we have to know how to design the right emergence profile of the interim restoration, the provisional. Okay, and this is paramount in order to avoid damaging the hard and soft tissues. Our goal is this, to end up with an implant in the right position, orthodontically driven, and with enough hard and soft tissues, with enough quantity and quality of hard and soft tissues on the back side of the implant. In order to get those results, sometimes, as I said before, I graft a connective tissue graft under the gingiva on the back side. It hasn't to be very big, only around 1.5 millimeter thick, from the mesial to the distal papilla, with a flapless approach. Of course, I fill the gap between the implant and the cortical plate with a biomaterial. And the goal of this kind of procedure is to overcorrect the dimension of the soft tissues, mainly in those patients with a thin biotype. With drawings, I could show you the procedure. This is the first step, an automatic extraction, and I try to use systems like Extract or Benex in order to preserve the integrity of the cortical bone plate. But sometimes I can do it with a forceps, of course, and sometimes from time to time I need burrs, because many teeth are quite difficult to extract, as you know very well. And these are the systems I usually utilize in those clinical situations, and they are comfortable to use, and they don't work in 100% of the cases, because sometimes we face teeth with vertical fractures, and we cannot use these devices with those kind of situations. But in 90% of the cases, they work quite nicely. This is the procedure I use. They have different kind of posts that you screw into the root, and with you pull from the root, and finally you get a socket without any damage of the cortical bone plate. I try to place my implant always with a flapless approach, as I said before, and in order to graft the connective tissue graft between the cortical plate at the gingiva, I use a micro surgical procedure using these micro blades. There are many in the market, and all of them are quite useful. In order, some of them can be bent even in order to adapt the microblade to the anatomy of the crest, the bone crest. Finally, I introduce the connective tissue graft into the pouch I created with the microblade. And the other key point we were talking about before is how do we manage the emergence profile of the temporary restoration. And when an interface is needed, it's important that the emergence profile of that interface comes straight from the neck of the implant, okay? Because if not, if the emergence profile is too aggressive, sometimes we end up compressing the proximal bone, and if you don't have enough space for the epithelium and the connective tissue, the bone gets resolved, and we don't want that, because after resolving, we lose part of the volume of the papilla. So that's the reason I distinguish three different areas. Two critical areas, and not one, like in the article of Su and Gonzalez. This is a nice article, but recently we published a couple of papers distinguishing these three areas. the E area. This is a aesthetic critical area next to the gingiva. This area defines where the gingival margin is gonna be stabilized. The C area is the second critical area. It's important that allows enough space, biological space, for the epithelium and the connective tissue graft. And the B area connects the C and the E area and is the subcritical, less critical area. So this is the more or less the contour we get when we shape the emergence profile of a central upper central incisor. This has been published recently by the three of us, myself, Dr. Esquivel, and Dr. Blach, the head of the Department of the Penn University. And this paper, everything is explained about how to customize the emergence profile of every single crown, because every single emergence profile is absolutely different. You cannot individualize a central upper central incisor like lower central incisor, because they are absolutely different. And the second paper I recommend you to read is another one. We've been published recently, but in another magazine, International Journal of Periodontics and Restorative Dentistry. The second paper speaks about how the emergence profile of the crown changes depending on the position, the 4D position of the implant. So in the end, the message is every single emergence profile has 3 areas, and those areas change with when the implant position changes. And it has to be individualized. Every single emergence profile has to be individualized. So what will happen if we have these different situations? Not every single case is equal. Sometimes the level of the gingiva of the tooth to be extracted is perfect, but in other clinical situations we have a recession or even our overcorrection. The gingiva is lower position. Is in a lower position. So if I have a recession, I always perform a connective tissue graft in order to treat the gingival recession. At the same time, I place the implant immediately. Okay, this is the result, and this is afterwards. This is the implant supportive crown. So I went from here to there through the immediate temporization. And you can see that we didn't get we didn't end up with any kind of aesthetic problem. We solved the aesthetic, the gingival recession. At the same time, we placed the implant immediately. And this is the final picture. This has been published in a local magazine by me many years ago. This is a case I did. This is follow-up 10 years later, but I did this case, I think, almost 20 years ago. This is PFM crown, implant supported crown. And actually, the girl was a dentist, and you can see the lack of volume of the papillae. So we performed a connective tissue graft. I harvested from the palate. And this is the follow-up 10 years later. So the procedure, the protocol, the workflow works nicely, in my opinion. You can see, of course, there are another workflows. For example, you can use nowadays a socket shield, or you can fill the gap with biomaterials to the neck of the implant. I don't know, many ways to go. But the philosophy is to try to overcorrect the volume of the soft tissues in order to avoid the collapse obtained during the healing process. And this is a single case, and this is the CBCT in order you to understand that we have not only gingiva, not only soft tissues on the back side of the implant, but I have actually bone 10 years later on the back side of this clinical case. Okay. So if the margin of the gingiva is level, depending on the thickness of the gingiva, I perform a thin connective tissue graft, but sometimes I don't do it if the biotype is quite thick. I place the implant immediately. You can see that in this clinical case, I used only 1 millimeter thick connective tissue graft from the mesial to the distal papilla, around 3-4 millimeter wide, and it's more than enough, you see here, in order to stabilize, to thicken the biotype and to avoid any aesthetic complication in this clinical case. Always pay attention at the shape of the bone, of the hard tissues. Look at the apical quantity of bone you have in order to stabilize the implant, because as you see on the right, we don't have much bone in order to get primary stability. And most of the cortical plates are under 1 millimeter thickness, but we usually have more than enough height of bone in order to place implants immediately, around 18-19 millimeters of bone. So in most of our patients, and enough width in order to place a 4 millimeter diameter implant. In most of our patients, it is possible to perform implants immediately. This is a paper quite interesting, talking about the anatomy of the crest and how, in most cases, we have enough apical bone in order to stabilize the implant immediately, but we should use a CBCT scanner in every single case in order to check it out, in order to check that the enough quantity of bone is present, in order to avoid any kind of complications. Okay, what happens if when I probe the root I'm gonna to extract, I realize that I don't have a bone on the cortical, on the facial side of the facial aspect of the implant, of the socket. We can we perform the implant immediately in a predictable way, or this is unpredictable? This should not be done. I think that this, biologically speaking, is predictable. Of course, we need experience. We need to have some experience placing implants immediately. But we have many techniques in the market, and well published in the literature that explain how to do it. For example, here on the right, you can see I'm reconstructed the cortical bone plate with a bios collagen, for example, or with a bone graft from the tuberosity. Even sometimes this bone graft includes soft tissues at the same time. So this is a drawing showing more or less the situation in many many patients. We face those situations, and some authors say, hey, don't do immediate implants. In those cases, it's better to do delayed implant placement. Okay, that's a way to go. I don't have to say anything, but I prefer to reconstruct the tissues at the same time I place an implant immediately, because in that way I shorten the treatment time, and the morbidity for the patient is gonna be reduced. And you can see on the left a paper we published, my friend Juan Sofia and myself, in the journal Digital Dentistry, with a technique called the 4-layer graft technique, in order to reconstruct even very severe compromised sockets. So this we realized many years ago that we can use the socket preservation techniques at the same time we place the implant, saving lots of surgeries and time, morbidity for our patients. This is quite frequent in our offices, and I place the implant immediately in this clinical case, as you see, and I'm using bone block biomaterial collagen, bios collagen, in order to fill the space, the gap between the implant and the gingiva. I use these bios collagen bone blocks without any membrane because I'm working flapless. Then I don't need any membrane in my, that's my humble opinion, because I don't racing. I'm not racing any flap. Afterwards, if the primary stability of the implant is high, I even load the implant immediately. This is the emergence profile of the provisional restoration, and you can observe here the three areas I was speaking about before. The aesthetic area here, where there is a convex area holding, supporting the gingiva, the straight area, the C area next to the neck of the implant, in order to allow space for the epithelium, for the connective tissue, I mean the biological space, and the bounded area connected the C and the E area. Well, I finalized the temporary restoration, and this is a movie showing how did we finished at that time, years before, the temporary restoration and the emergence profile design. Of course, this is analog. This is the analog way to go. It works nicely, but it takes lots of time and expertise. You have to shape with composite the emergence profile, to polish, to shine everything properly. It takes half an hour to do this sometimes, depending on the quality you want to reach with your temporary crown. You will see at the end of the presentation that nowadays we don't use anymore this workflow because the milling machine is working for us. But of course, it works nicely. And this is a clinical case I performed more than, I think, 10 years. I cannot remember exactly. This is the follow-up 7 years later, and I reconstructed the heart and the soft tissues with a graft harvested from the tuberosity. This is not exactly the technique published by Manuel de la Rosa. This is a modification by me. That is what we published in the International European Journal of Aesthetic Dentistry a couple of years ago, Juan and me. But I'm showing you this follow-up because it works, and we've been working with this protocol for quite a long time. And at that time, of course, everything was done analogically. And you can see before and afterwards, 2 months later, the result. The implant is perfectly osseointegrated. The heart and soft tissues healed properly, no problems existed with this implant. And this is the customized abutment and the final restoration. Of course, you can do more or less the same for a full arch. We are speaking about single teeth, but for a full arch, we can combine the digital plan, surgical guide with the temporary restorations and the soft tissue approach in order to reconstruct everything, even the bone, the heart, the soft tissues, and to place the implants immediately. And if you do it in the proper way, it works nicely. And this is a temporary restoration because we had to do it like that because the malocclusion of the upper jaw. But after some months, we changed everything and the upper jaw with orthodontics. And this is the final aspect of the final aesthetic of the restoration. We avoided with the heart and soft tissue reconstruction to end up with a hybrid denture Of course, a Harvard denture is a good option for many patients, but many other patients prefer an FP1 restoration. And this is before and afterwards, later on, the follow-up. So the digital world comes and everything changes very quickly. And why so? Because digital dentistry allows us to perform the same techniques in a more efficient way. You are not gonna become a better dentist because you have an intraoral scanner, but you can do the same thing in working much less. Of course, we should consider that it is necessary to have experience in this field. We have the scientific evidence, already have the scientific evidence, and we always have to consider the patient's needs and preferences. And remember, evidence changes. Evidence-based dentistry changes every single day, every single year. So we have to change with it because everything is changing. The constant word in this, the word is changing every single day, and the evidence-based dentistry in the same way. So for me, a state-of-the-art implant dentistry is the one who combines the new technologies with the hard and soft tissue management. And of course, we have to know the design of the implants we are using. This is quite relevant. If we combine all of these new technologies with the knowledge we have of the hard and soft tissue reconstruction techniques, with temporary restorations, emergence profile, immediate loading, we can do amazing things nowadays. We can transform the transition area, the mouth of a patient, in 2 hours, 3 hours, 4 hours in the same morning. We have a long experience doing this. This is quite unbelievable because when I finished my degree, I couldn't imagine I was going to do this kind of dentistry. It was impossible at those times to do this. But nowadays it's quite possible. It's very, very predictable. And the only thing you need is to study the techniques, to study the evidence, and to combine these techniques and this evidence with the knowledge of your system, implant system, and the knowledge of new technologies and softwares. And as I said before, it saves times, it saves morbidity for our patients, it saves money as well. That's also important for our patients many times. From here to there in one single morning, working only a few hours, something unbelievable many years ago. Sorry. So digital workflows come to our office, and from finishing our cases in 3 steps, sometimes it started to finish our cases in 2 steps, something unbelievable. Not only that, printers and milling machines are incorporated in our workflows and allowed us to do this. This is a clinical case. You can see the inflammation on the back side of this premolar. The patient feels pain. Maybe we have a vertical fracture. We have to reconstruct part of the cortical bone plate with no problem at all. As I said before, I place the implant immediately, I reconstruct the bone, and what is amazing is that now I can take easily an impression with a scan body. At the same time, I place the implant. Now, not anymore, I'm gonna perform myself, I'm gonna shape myself the emergence profile. I'm gonna use an interface with a immediately milled temporary restoration. The milling machine is working now for me, and I comfortably finalize this clinical case, the connective tissue graft, the hard tissue reconstruction, or whatever. Or I can see in this half an hour, I can see another patient. But of course, I need an interface, and I needed to cement the temporary restoration to the interface before going into the mouth and to place the temporary restoration. If you want nicely done temporary restoration, you can dye it I seldom do it nowadays because with the new materials we have, the aesthetic is unbelievable, but you can do it if you want. And of course, if I need a connective tissue graft, I harvest it, in this clinical case from the tuberosity, or the clinical case from the palate, or whatever you have more tissues, wherever you have more tissues. And I finally screw the temporary restoration onto the head of the implant. And this is the final result. And the most amazing thing about this digital workflow is that now the contact points and the occlusion is perfect. It's like it's the perfect occlusion I designed into the software. I don't have to readapt the contact points or the occlusion. That was something quite tiresome sometimes with the analog workflow. Wait, sorry. So sorry. Wait a minute. Wait, sorry, I touched the wrong key. Okay. Let's see how we do it. And look at the design of the interface. I
Excuse me, we can't hear you. Can you hear me, Valentino? Maybe it's because of the video.
filling the gap with biomaterial, reconstructing the cortical plate, whatever you need to do. So the milling machine is gonna be working. Meanwhile, I'm finalizing my clinical case or performing another surgery in the same patient, or going to another box to work with another patient. And look, how do I perform the emergence profile right now with the pencil? It's much easier than before. Of course, I reduce the occlusion because this is, I don't want hard contact points. And this is a huge advantage. If you want to push away the gingiva, you can modify the design as you want. And here it is. Finally, we cement the temporary restoration to the T-base. I cannot imagine nowadays to do this analogically because it was much harder. And this is the result, the radiograph and the CBCT immediately after the surgery. A few days later, everything is perfect. The patient didn't feel any pain, or there was not any swelling. And after some weeks, this is the condition of the shaft tissues. And look, when I unscrew the crown, the healthy shaft tissues. Finally, the only thing I have to do is to order my final restoration to the technician and to change the temporary restoration for this one. Okay, so now we are able to perform a clinical immediate implant and to finalize it in only 2 clinical steps, because 0 is the day I saw the patient for the first time. 1 is the day I perform the surgery with the hard and soft tissue reconstruction, and the temporary restoration immediately placed. And finally, 2 months later, I can deliver 2 or 3, 4 months later, can deliver the final restoration, the final prosthesis. What about several teeth? What about those situations where I face several teeth with a decayed situation. And you can see here, I took out the roots, but I left part of the root of the first premolar in order to preserve the integrity of the cortical bone plate. You can see here that I used a socket shield in order to do this. I cut part of the root only, and at the same time, I screw a couple of multi-units. This is the picture combining immediate implant placed, an implant placed immediately, an implant placed in a healed site, and a partial extraction therapy. Then, what is a great advantage is to have the possibility to scan, to take the impression. At the same time, I do the surgery. Something that it was quite awful with the analogical procedure. Afterwards, I design the temporary restoration. Of course, I don't want much occlusion here, and I say to the patient, please don't bite with this side of your mouth. Use the other side. A couple of months. But nevertheless, this temporary restoration is gonna shape the emergence profile of the soft tissue. So that's the reason I prefer to use the temporary restoration immediately. In that, this is something. This is the transfer, digital transfer, digital scan body, but they can be used as in another way. Designed a couple of years ago, I think it's quite useful for these clinical cases. After a couple of months, I screw these scan bodies into the implants head and re-scan everything in order to redesign the final prosthesis, because you have a shrinkage of the gingiva after several months. So in these cases, I prefer to re-scan the situation of the soft tissues after several months, but this is done in only a few minutes, and you don't risk any kind of, you don't have to face bubbles or any kind of complication. This is a straightforward procedure, as you know very well. So digital dentistry nowadays is something that is much easier to learn than the old-fashioned workflows. And Tanya is gonna design the new prosthesis. And using exocad, but you can use 3Shape. Or there are many other softwares into the market. That is not important. We overlap the STL files. And now, after several months, after the osseointegration of the implants, we can readapt the occlusion of the new prosthesis. And afterwards, everything is milled in zirconia. This patient, you see this kind of occlusion because the patient had some teeth from the upper jaw extruded. It is not the perfect occlusal situation. Then the only thing you have to do is to cement the final prosthesis onto two interfaces, and everything is done. We work only a couple of days, and finally we deliver the prosthesis. So much easier than many, but the decades ago. We have a long experience doing this kind of procedure in full arches, but this is another topic. What happens if we eliminate the interfaces? And here comes the matrix implant, a new design, a new connection design in order to avoid using the interface between the temporary restoration and the head of the implant. In that way, we are able to speed up even more the treatment. We are able to save money for our patient, and we compensate. Let's see the video. Yeah, okay. we we can compensate the lack of the interface with a new design of the head of the implant. You see that there is a kind of notch into the head of the implant that allows only one single position of the temporary restoration or the final prosthesis, but it has three groups for the implant insertion and a platform switching concept at the same time. Not only that, the design of the connection is rounded in order to ease the milling procedure of the machine and to end up with a more precise adaptation between the the prosthesis and the head of the implant. We have two different designs, bone and tissue level, two different connections, 3.7 and 4.5. And what I love about the narrow connection is that they have this kind of concave design we've been publishing lately and talking about it because it allows more space for the biological concept for the epithelium and the connective tissue in order to avoid the bone remodeling around the neck of the implant. Of course, for the tissue level implant, following the old design of 3 implants, we have an anodization of the head of the collar with a pink color. In that way, we have more space for the tissues with reduced cost. We don't need any interface. We have also the possibility to angulate the crown because till 20 degrees, I think. So many advantages we didn't have with old-fashioned connections. So we can choose between analog or digital wear. We can send our impressions to the laboratory, but in the end, nowadays, every single design is done digitally. So I think the more efficient way to go is to go for digital workflows. And finally, everything is manufactured and deliver to the patient. So that's the reason I use this kind of 3D rule in order to teach about the data generation, design, and delivering, the 3D steps. And finally, I want to show you some clinical cases, and I would like to reason why I do use sometimes narrow connection or a wider connection. Why I decided to combine different kind of implants designs in order to properly finalize my clinical cases. I really love tissue level implants, and that's the reason the 6 cases I'm gonna show you are tissue level implants, because in that way I keep the gap far away from the crestal bone. But of course, that's a personal opinion and nothing scientifically based. Okay, the first clinical case is this one, with this a simple case, a premolar in the upper jaw. And all of them, except one single clinical case, are done with a surgical guide, digital plan surgical guide, in order to place the implant in the 3D proper position, prosthodontically driven. You can see the design of the surgical guide, and as I said before, I try to preserve the integrity of the cortical bone plate using this kind of systems. In this occasion, I use extract system, and following the extraction of the tooth, I prepare the implant bed, and I place an implant with a narrow neck. You can see here I choose this implant design, the 3.7 for this premolar. Why so? Because you can see that here in this premolar, I have to place the implant a little bit deeper. If the neck of the implant is too wide, I'm gonna compress the proximal bone, and that bone is gonna be resolved very quickly. I decided to place the implant a little bit palatally and to reconstruct the bone at the same time of placing the implant immediately. Of course, I scanned the position of the implant, and I designed temporary restoration that here is a little bit too wide because the patient has to rehabilitate the whole mouth. You can see that the space for the upper molar is too wide in this clinical case. You see that once again I used bios collagen in order to reconstruct the cortical bone plate resolved because of the fracture of the previous of the root, and I used a connective tissue graft harvested from the tuberosity. This is the situation after the suture, after the reconstruction of the hard and soft tissues, and then at the few minutes later, after finishing the surgery, Tanya delivered the final temporary restoration, and you can see that the occlusion at the contact points were perfect. And that's a huge advantage because years ago I had to adapt the contact points. I have to check the occlusal situation, but now this is something we do with high precision with the help of the softwares. And you can see here on the left the radiograph, and you can observe that when I place the implants too deeply into the bone, because I need to, I prefer a narrow design of the head of the implant in order to avoid any compression of the proximal bone, as I explained previously. Another tissue level implant was placed in the lower jaw, but this tissue level implant was placed with a wider design and supracrestally. It's quite different because in the lower jaw, the implant was placed in a healed site, in a healed bone crest. Of course, those concepts are very important when you face more complicated cases. But I want to speak only about simple cases in this lecture because this is something new in the market, and most of these cases are not finished yet. I placed this implant during the last months. Sometimes I can use a narrow design of the neck of the implant, even for a wider tooth, for a molar. Why so? Because in this clinical case, planned digitally as well, you can see the surgical guide, and I opened a window on the lateral side of the surgical guide in order to have more spacing to introduce the burrs. I took out the molar, and with high precision, we placed the implant. But it was necessary to place the implant and the bone crest and the most coronal part of the bone crest. And when I do that, I prefer, once again, to avoid any compression of the proximal bone or sometimes the lingual bone. I fill the gap with a biomaterial and stabilize it with a sponge. And this is the result 15 days later. Very simple surgery here done with a prefabricated healing cap. Okay, So in those clinical cases, the narrow design was used. You can observe here how the implant is placed a little bit deeper than in other clinical situations I'm gonna show later on. And the reasoning is explained here in this paper I published with Esquivel and Dr. Blach, my good friend Esquivel and Dr. Blach just recently this month. And I recommend you as well the paper Esquivel wrote about the influence of the implant position in the design of the emergence profile. Because we are talking about when we change the depth of the implant neck, everything changes. Everything has to change. Let's look at the movie video of the procedure, the first clinical case. Always trying to be minimally invasive, preserving the cortical bone plate with the extract system. Using a guided surgical stent to place an implant is quite easy. You see here the digital plan surgical stent, and we already finished the preparation of the implant bed. We check the cortical bone plate, and we observe that we don't have any bone on the back side of the implant. No problem at all. The stability, the primary stability of the implant is quite good because we use the apical palatal bone. Nevertheless, we check it out. And with the macroscope, we observe that no bone is present on the back side. So in order to reconstruct the facial aspect of the bone, we are going to use bios collagen. But before that, we take the digital impression, because then Tania is gonna work designing the temporary restoration. Meanwhile, I finalize the surgery using a connected tissue graft harvested from the tuberosity, as you see here, combined with the reconstruction of the bone with the bios collagen. 2 matrix horizontal sutures are used in order to stabilize mesially and distally the connective tissue graft on the facial aspect of the implant, and at the coronal level of the gingiva. Of course, I don't want to suture this connective tissue graft in the middle part of the socket. I want to keep it in the most coronal part of the gingiva, internal part of the gingiva. So now the gingiva is going to be thickened because the internal aspect of it is reconstructed with this quite thick connective tissue graft. You have to consider that in those cases, sometimes the shrinkage during the months after the surgery is quite paramount. So we should overcorrect that dimension, the quality and quantity of the soft tissue. So that's the reason the temporary restoration is a little bit shorter and straight. It's designed, you can see it's designed in order to keep enough space for the bios collagen and the recently placed connective tissue graft. I don't want to create any bulking of the gingiva. So this is a quite straightforward procedure. And another case, not only in the anterior area and for the molar, you see, I planned the surgery, and afterwards, immediately afterwards, I placed the implant. You see the precision of the implant placement, and it's 3D position immediately. But now if I have a better primary stability, why do I use in the previous case a healing cap, and now I modify the technique? Because I'm gonna modify the technique. In this clinical case, I gonna customize the healing cap, and I'm not going to mill a temporary restoration, because to load this implant immediately, this lower molar is quite risky, because the patient is gonna bite quite hard in this area of the mouth. So, but I want to stabilize the blood clot, and in order to preserve the volume of the hard and soft tissues, I fill everything with biomaterial, the spaces between the cortical plate, the plates, and the implant, and I want to keep it stable, to keep the biomaterial and the blood clot stable. And in order to do that, I mill customized healing abutment, or a customized healing cap. Look at this. I don't need now. This is a huge advantage, because I don't need any interface. I don't need any T-base, and you can see here the clever design, rounded design of the new connection. And you see that I'm gonna screw the healing cap immediately onto the implant head without any interface. So I preserve the anatomy of the hard and soft tissues. Why didn't I use this procedure before? Because it depends on the primary stability you get with the implant. If you don't have enough primary stability, is even riskier to use this kind of approach. It's better to use a prefabricated healing cap. But if the primary stability is good, you can use this procedure and to stabilize without any suture the anatomy of the soft tissues. And this is the result. And I want to show you this clinical case in order that you to understand how clever is not only to use this design without any T-base, but to use a concave collar design, a concave neck of our implant. Because look at the adjacent implant. In the adjacent implant, we have a straight design, a narrow design of the abutment, and look at the bone after many years. You see, the bone is preserved, and that's the reason. Maybe you think, hey, this collar, this implant collar is too narrow for a molar. But look, I'm thinking about this. I'm thinking about the future stability of the bone. I want a different design of the emergence profile in the C area, in the area in contact with the bone. Next to the bone, I want a space for the hard and soft tissues. Because when you don't have much space for the hard and soft tissues, look at the implants in the upper jaw. There is bone remodeling. You can see that there is bone remodeling around the neck of the implant. So what is the meaning of these wide neck implants if I'm gonna lose the bone? I don't want to lose the bone. I want a bone, a stable situation after many years. But sometimes I change my design, and I prefer a wider design. Why so? Look at this clinical case, and these are premolars. And I take out both premolars, digitally planned. The surgeries were once again digitally planned. This is the surgical stent, printed surgical stent. This is quite amazing. Sorry, I want to explain to you that this is done into my office. So this is quite cheap. Many years ago, I paid more than 500 euros for this, but now this is very cheap. This is printed in my office. And now I'm gonna use the wider design of tissue level implants. I performed the surgery and I place the implant. You can see immediately. And why so? I'm using, Ramon, I don't understand anything. Why do I use now a wider design? Because now the implant is placed more shallower, and it's not so deep into the bone. Then the idea is more or less the same, but they change the position of the implant. So I can place the implant more at the level of the gingiva. And I perform the surgery very quickly because I fill the gap only with a collagen sponge. And I use a prefabricated healing cap. I look at the aspect of the tissues 1 month later. But pay attention to this. In this clinical case, the bone, the cortical bone, the facial bone was very thick. I didn't need any biomaterial. I didn't need any connective tissue graft. And the patient had cancer 1 year before. So I didn't want to perform any complicated procedure. So what I did is to change the position of the implant. I ended up my surgery with a shallower implant. You can check it out here. So I'm not compressing the bone because the implant is shallower. And later on, I can register the position of the implant because here I didn't took the impression immediately because the patient didn't have a good quality of bone. She was not fully healthy. I didn't want any risk, or maybe your patient don't have enough money in order to do the temporary restoration immediately, whatever. Sometimes we don't load the implants immediately, or you don't have the main reason is you don't have enough primary stability. But it wasn't the case in this patient. And finally, I designed the temporary restoration. And when I designed the temporary restoration, once again, I talk about this. Look, now I change. It's the emergence profile is changing, and it's explained here on the paper. It's not really changed. What happens is that the C area is the color of the implant, of the tissue level implant, because now the implant is placed more shallower. And you see this kind of design, 3D design drawing in my paper that explains exactly what I'm doing here. I don't have much time I have to finalize my lecture. I don't have much time to speak about this, and this is not a lecture about the emergence profile this time. But at least I have to explain this very, very quickly. But if you are interested about the topic, please read the paper and you will understand what I'm doing here. Of course, sometimes in healed sites, I want to perform a single surgery. This is the only case I have without any digital plan surgery. So I went the free hand here. I took out the connective tissue graft in order to compensate the concavity of the ridge, because there was a mild bone resorption, and I placed the implants freehand because the surgery was quite simple, and this is the result. But you can observe that the precision of the implant position is not so good, and I wanted to show you this, that I almost touched the second premolar apex. I didn't, but I almost, even with my experience, more than 20 years placing implants, I prefer to place all of my implants, even the simple ones, with a surgical stent 3D digital plant, because it's safer, it's quicker. And look at the last clinical case. Look at the clinical case. This was done with a surgical guide 3D plant once again. And look at the precision of the implant placement. And right now, I'm using once again the tissue level concept, but now once again with a shallower position of the neck of the implant, supracrestally, not subcrestally. Then I'm not gonna compress the bone because the site is healed, the ridge is healed, and the implant is gonna be placed supracrestally. And look at how the tissues healed properly, and look at the crest without any grafting. bone grafting. And look at the position of the implants. Thanks to the digital planning, nothing compared with the previous case. So I recommend you digital workflows because are much quicker, more precise, more safer. You have many advantages using digital workflows. After some months, I'm gonna take out the implant you see here because I don't like the condition of that implant, and I will place with, we will finalize this clinical case with 3 crowns screw onto these 2 implants. But this case is under treatment because we are using nowadays these days Invisalign in this clinical case in order to precisely place the implant, the teeth in position. So my conclusions: short and medium term studies show that immediate implants and delayed implants more or less get the same results. So this is predictable. And temporary prostheses are mandatory to achieve optimal result, but not enough. Many times you have to reconstruct the hard and soft tissues, as you said before. These new designs have changed the way we practice nowadays. I think there is a bright future for these new ideas in our practice. This is not something scientifically proven, but this is something clinical proven as well. It has many advantages. It saves time, it saves cost. It allows us to work without the titanium base abutments, even combining angulated implants. So choose whatever you want. You can finalize your cases with a good quality in analog or a digital world, but the digital approach has, in my opinion, many advantages. Finally, there is no magic in magic. It's all in the details. I really like this quote by Walt Disney. I miss my travels all around the world and my friends mainly. I hope that someday we are able to come across once again to see each other, not throughout a computer. This is quite cold. Of course, it has advantages. I'm here at home lecturing for you. Last year I was traveling every single month, but whatever. I hope to see you here at my office all around the world, whatever you want. I want to thank you for your patience. I think it's time to finish. You can visit my Instagram profile or write to me via email, whatever you want. If you want to ask me anything I wasn't able to explain properly during this lecture, I had too many slides, so sorry. I had to speed up a little bit.
Don't worry, it was a fantastic presentation. Thank you, Ramon, for this great introduction from different words, from an analog way into the digital way. And I myself are very impressed about to see, for example, this video you showed of the analog way to mill and design the tissue, design the emergence profile for temporary with the standard procedure. And you were saying it takes you about a half an hour just to create this form by hand in a certain way. And with this new technology, especially with the matrix technology, I think it's such an amazing advantage, time advantage, quality advantage as well, because you can use this, as you showed in this patient-based healing color, which you milled there. And that was very in the beginning. It was one of the first cases I can remember. And you were able to do that in your office, chairside. I want to switch quickly to my presentation slides, but now there's popping in a lot of questions which we have to answer. I want to ask the first question, which comes from, I think, from Germany. There was a question: what milling machines are you using chairside to create this healing individual patient-based?
Amann Girrbach.
And the chairside
Actually, it is German. It is German. Amann Girrbach.
Amann Girrbach, yes, and I would like to add maybe there from TRI side. 1 second, I just have to change quickly to my slides that we don't see your desktop anymore. Yeah, I think from the industry side or from TRI side with this matrix technology, we are 1 second. We are able.
Yeah. Actually, I was lucky because when you said that you were working with Amann Girrbach, if you remember, I already had Amann Girrbach. I had been working with it for many years, so for me it was quite easy to introduce the new workflow because that was already our milling machine.
Yes, and actually for us from TRI side, we can really say here, I mean, this presentation right now was really the very first time worldwide that we showed results of the matrix, and I think this lecture now shows the possibilities. It's endless with the matrix connection. We are
absolutely
possible to mill any designs, and it has not to be a chairside. You can many of you as doctors have your laboratory very close to just a few meters away from your office, and so it's absolutely possible to work in these workflows as you found out for yourself, and this is what the matrix connection does. It opens the ideas of the users to create however their prosthetic in the certain materials we are allowing them to use, which are stable enough, and so on. And one big thing I just want to mention before we go into the questions, it's very important that we have also with Amann and Girrbach, we worked out, Amann Girrbach came to our office and they said like, wow, they want to improve the milling connection strategy. So the connection, the platform 3.7, 3.4.5 is milled by a strategy made by, for example, Amann Girrbach. There's many other companies which are working. We are open system, as I said in the beginning of my presentation. We have an open interface here and closed system, because this is leading to the first question here of a German, or as well as Stefan Fabel. He's asking if it's possible with CEREC. I think in the future CEREC is a closed system, and but due to the fact that this connection is
well, if you allow me to say, Holger, I think I don't have CEREC. I have many friends of mine that who have had CEREC for many years. It works nicely in a way, in a chairside way, but I didn't buy CEREC because I quite frequently perform full arches, you know, at my office. And for full arches, I needed an open system with the possibility to mill a full arch very quickly, you know. That's the reason we start with Amann Girrbach. And but of course, in the future, consider that CEREC is a very nice procedure, a very nice way to do chairside PMA restoration or final restorations for one or several teeth. But the problem with me is that I needed something for full arches, you know, for temporary full arches. So that's the reason I started with Amann Girrbach. And I want to say that for us, for dentists, the digital world is something relatively new, but for technicians, they've been working with milling machines for many years. So is nothing new. Every technician is used to the milling machines. So in the next few years, all of us will recognize that it's much more expensive to work in non-analog way than in the digital way, because that time is very expensive, and not only, and it can be even more expensive in Germany or USA, where the quality, where the PI or the cost of life is higher. You know, here is the problem with the first word. The time is very, very expensive.
Yeah. Yeah, I think it's a big time saver for the digital workflows, and also, I mean, with the matrix, you don't have a big stock of abutments in your office. You don't have to learn your stuff a lot about different abutment components and cemented versus screw retained and so on. It's really going more and more in this plug and play situation that we created here with this matrix connection, that the interface to the digital work. But there was one question, and maybe it's a question more to us. There was the question, how do I have to be digital equipped to use the matrix connection? No, you don't have to be digital equipped as a surgeon. You can place your implants completely normal, as Ramon said. We have the 3D touch as an open tray impression post, which you can use in a normal way, in a open tray technique.
But the technician is gonna digitalize your impression. No problem
exactly.
at all. Is the way we were working 10 years ago. I was working only with analog devices, but my technician always digitalized every single impression.
Yeah, and then I think that the time saving was a question here as well. I combined into the analog way to create, let's say, a single crown healing color combined, and to the case you showed with this premolar PMMA healing. What would you say the time saving you had there in this case?
Sorry, I was reading. Sorry, you were asking about the time setting.
Yes. And the time saving between the analog way to veneer something with veneering material, and the milling chairside.
I don't know exactly what is the time saving, but for full arches, for a single crown is quite relevant, but for full arches it's huge. It's huge because because we are working nowadays with PMMA temporary restoration, which seldom break. I don't want never, but seldom break. This is very, very cheap. It's much cheaper than before. And we finalize many times with zirconia full mouth rehabilitation. And in the future, if we are able to save the T-base, the interfaces, it will be even more cheaper, even cheaper than before. So if you consider the time and the savings from the materials, I don't know exactly what is the difference, but I can tell you that once you start doing this kind of dentistry, you never go back. You never go back. You know, if the intraoral scanner gets broken or doesn't work, you change the appointments, but you never go back. You never. It's very tiresome to do those kind of old-fashioned workflows. Some days ago, a colleague told me, you know, that sometimes doctors don't understand what we are doing, dentists we are doing. And I said, you know what? I think many dentists don't understand what other dentists are doing. Because if you see how do we work nowadays, and you watch the way we worked 10 years ago, it's another world.
Yeah, it is, and it will change always. I mean, if you think what cars are passing here on the road outside, and how fast they change, and so we have to go with the flow.
More or less the same. Or with the mobile phones, for example, the same.
For sure, with the matrix, you are on the right track. There's another question, a big question. June, Kit, Loy, I don't know where you're from, but your question was about the stability, about the materials, because we screw retain directly on the implant, so the zirconia would screw retain directly on the implant in single crowns, bridges, and full arches. Yes, we do. That's what we do. It's absolutely clear that all these materials are tested. We allow only a certain strength of zirconia to use. You cannot just use any material you want. It must be in a range, in a certain range from the stability of the material you use. But as I explained in the beginning of this presentation, the matrix connection, this smooth base, these flat parts are made and designed for having the strength to hold the connection close together. This is one thing. The second thing is the screws which you use for each material. You're going to use a different screw. So for example, for titanium, we have a different design screw head, for example, as for zirconia, which is proven, and this is giving you the stability for this connection. I hope this answers so far the question. There was one question to you. I think I wrote it down here. What when you have this patient-based designed healing colors, would you say you never use a membrane anymore? You just cover everything as you explained. You don't. There's no need for a membrane. That was the question.
Absolutely unnecessary, because the only goal of that customized healing abutment is to stabilize the blood clot. So don't waste your money using membranes. Of course, they work, but they work if you have a prefabricated healing cap and you need to stabilize with the membrane the blood clot. But if you already stabilize the blood clot with the healing color, don't waste your money, because it's gonna work nicely. You will see. I have experience on this, because before we did this with composite, many years ago, freehand. But of course, this is a way to do it in a much quicker, because my assistant, my hygienist, is the one scanning the 3D position, and Tanya is the one designing the customized healing color. So this is a team approach. Meanwhile, I'm working with another patient. So nowadays, everything is changing very quickly. Don't use a membrane for this kind of. Be sure it's gonna be successful.
Okay. Thank you very much, Ramon. I think we are running out of time. I would just like give quickly to Peter Buscha an answer, and I say thank you to you already again. When there is coming more questions the next 5 minutes, we will pass them to Ramon and give you an answer for sure. And the question was from Peter: how is the stability of the micro gap with the abutment implant information? And I just want to show in this moment one quick slide, which is very important, because it combines a little bit the CEREC question and Ramon works with Aman and Bierbach. It's where the key is also in milling strategies. We use milling strategies. All the common companies, like the named companies we are talking about, we are very close in contact with Ivoclar, and all these companies, and we create for the milling machines. We create different strategies for the platform 3.7 or the platform 45, or we have created, and this gives us an accurate connection between abutment and implant, which is with the right milling machine, with the right milling strategy. Strategy is it perfectly fitting, sealed fitting with a flat base. And I just show you one picture quickly here. And this is the design of the interface. So the drill of the millings, it's following always a given. So the millings machines, they will recognize, oh, this is the matrix P37 or P45, and then they mill after this with an accurate way, which is given, which is in the milling strategy in the software, and they mill a super accurate design here. And that's why we are able to have a super high connection. If you zoom into here where the base is, this is how this connection looks under the microscope. So we are super accurate here and stable. Again, I would just like point out that we have the full market release of the matrix connection soon already, and I would like you to mark the date 18th of June in your calendar, because we have a super big special event in the 18th of June. We call it a hybrid event due to the fact of Corona. We still don't know, can people join us here live in Zurich, or is it more an online-based event? But that's why it's a hybrid event. We have both situations. For sure, Ramón Gómez Meda will be with us here in Zurich and have his presentation. And there will be a lot of workshops and more detailed information about the matrix in this day. Please sign up for and save the date for 18th of June for the full launch of the matrix technology. We also will be in the IDS in Cologne, which is taking place this year, not in the springtime. It will be in the 22nd to 25th of September, where we also plan to have a lot of workshops besides the normal booth and exhibition of the IDS in Cologne. And last but not least, I would like to ask you the last question. Are you ready to take the red pill? I think you all remember the Matrix connection, the Matrix movie, and there is always a choice. Are you analog or digital? And with taking the red pill, I'm very sure you are all ready for the digital workflow. And so please, if you have more questions regarding the TRI matrix, then please write us, pass us a line on matrix@tri.swiss. And we're going to answer you. We can give you more information about the matrix. You can be in your country the first placing this matrix very soon. So get in touch with us. And again, thank you very much, Ramón, for this great presentation.
Thank you. Thank you.
Stay safe, stay healthy, and hopefully we can celebrate together.
Same to you.
18th of June, and have a great day. Thank you very much.
Bye bye, Holger. See you soon. Bye bye.